All right, everyone, welcome to Grand Rounds. A little chilly this morning, put the fleece on. That's the first decision you make in the morning, right? Which fleece to put on, at least in my mind. Everything else is automatic. This today's CME code. Okay, supplied by Will. 140 years ago, the construction of the Brooklyn Bridge took 14 years. I don't know how many people perished, but probably wasn't a small number. Tomorrow is the start of Shavuot, a 3-day Jewish celebration of Moses' descent from Mount Sinai with the 10 Commandments. Seems like we have a lot more than 10 in our lives these days. Everyone's putting on, and they turn them into CME courses or online videos that you got to pass rather than, tablets of stone. Monday is Memorial Day holiday, honoring U.S. military personnel who died while serving in the armed forces. Some new degrees. Irena Vella completed her doctorate in nursing. A little round of applause there. And Brian McRory completed his master's in health science. That's like 2 snaps, not a clap, because he's already got an MD. All right, benefits. You still have time. The dental is the one that I've been getting the most questions about. You got to go to Duke at Work. Then you got to go to My Info. You got to find the little red arrow near the bottom right. Click on it. You've got to say if it's your dependents, and then you got to say if you want A, B, and C. You want A unless your dentist is in B or C. Then you have to select that you're taking the same amount of life insurance with no supplemental, and then you decide voluntary short-term disability. Feel free to take it. It's not required like it was in the PDC, but you don't have to take it. We'll cover you anyway. All right. A research roundup. Ann Augustine was the author of a study looking at the prevalence of trauma-associated sleep disorders amongst veterans, and Tatiana Segura looked at inflammatory cell populations in her microporous annealed particle scaffold maps. Marjorie Soltis, why I love neurology, when you have a good outcome. So in dementia clinic, we never have a good outcome, and that must explain some things. But she has some good outcomes, and it helps her form a bond with the patients. That's very rewarding. Thank you, Maggie. Our website now has a new APP section. We invite you all to go there. Will has done this, and he's got a new staff section as well as faculty. And anyone with recommendations on what would be helpful there, please send them to Will, because we're trying to build out these things and make them useful. I think Megan just did a review of the staff to see if they're using the website. June 7th, after Grand Rounds, is our picture. Bring your white coat if you're so inclined. Okay, a little update. I think I started this year with the Joro spiders, and they're coming. Look at those things. This was in the New York Times on Sunday, telling us they're really nice. They're nice, these spiders that have 10-foot webs that they use to parachute around the country. So look where they are now. They're all the way to Alamance County in North Carolina. That's right here. They're also in Davidson and out here in Buncombe County. So they're coming. If I see one of these in my backyard, you'll hear me screaming wherever you're living. I don't care how friendly they are. They are disgusting. And here's again today's CME code. Oh, look at you. You're a professor of medicine. When did that happen? Good for you. So today's presentation is Daniel Parker. Daniel is one of our memory docs, and we are thrilled to have him. All right, Daniel, which one is you? Here it is. Okay, gotta share the screen. Share this. Share. Presentation. Okay, floating controls. All right, baby, take it away.
All right. Well, thank you for the promotion. I'm very honored. So today I'm going to be talking about case of amyloid-related imaging abnormalities, or ARIA, which I think we're all going to be hearing a lot more about in the future. Okay. So this in memory clinic, I saw a 68-year-old gentleman who presented with 3 years of progressive short-term memory decline. This was back in March of 2021. He had no family history of dementia. We did a MOCA. It was 21 out of 30. At the time, he was still functionally independent, still working, and came with an outside MRI that showed bilateral hippocampal atrophy. So at the time, the working diagnosis was amnestic mild cognitive impairment. And we discussed doing a lumbar puncture to determine whether or not his symptoms were due to Alzheimer's disease. And so we did lumbar puncture and sent it off for the Mayo AD evaluation. And that lab test measures 3 proteins. So it measures A-beta 42, which is the sticky A-beta oligomer that accumulates into the plaques, total tau, which is a non-specific measure of neurodegeneration, and then phospho-tau 181, which is a specific marker of Alzheimer's disease pathology. And so this test, the way this test was designed, it was designed to predict whether or not someone would have a positive amyloid PET scan. And so when they were developing the test, they found that rather than using these single biomarkers to predict whether or not that PET scan would be positive, using the ratio p-tau to A-beta 42 provided better concordance with amyloid PET scan. So when interpreting this lab result, we look at the p-tau A-beta 42 ratio. And if that ratio is above 0.023, then that's consistent with the presence of amyloid plaques on amyloid PET scan. The positive predictive agreement with the amyloid PET scan is 92%. Similarly, the negative predictive agreement is also in the 90s. You can see, though, that if you look at the individual biomarkers in this gentleman, they were also very kind of consistent with Alzheimer's disease. So A-beta 42 was low in the CSF. Because it's aggregating into those insoluble plaques in the brain, and so it goes down in the CSF. And phospho-tau 181 was elevated. Sometimes when you get these results back, you may get an A-beta 42 value that's normal or just slightly above the cutoff, but we still look to the ratio, and if the ratio is abnormal, then that's still consistent with a positive test that person would very likely have amyloid imaging abnormalities if we did a PET scan. And so our diagnosis after the lumbar puncture was amnestic mild cognitive impairment due to Alzheimer's disease. At the time, aducanumab had just been approved. This was the first anti-amyloid monoclonal antibody that was approved. You probably remember it's a very controversial approval. There were 2 studies that were done to justify the approval, Emerge and Engage, and only one of those actually showed a significant difference with respect to changes in cognitive performance. Trials were also stopped early. There were dose changes, a lot of issues with the trials, and we were all kind of shocked that received FDA approval. But nonetheless, after a long discussion with the patient and his wife, he was interested in trying aducanumab, and so we began treatment with it. So 1 week after his 5th infusion, his wife reached out to let me know that he had developed some confusion, some visual changes, some mild headache and intermittent dizziness. So we got a stat MRI, and on the MRI, there was a flare signal abnormality in 4 distinct areas, as well as 7 new microhemorrhages. And so we made the decision to suspend treatment with aducanumab. So what was this finding that developed in response to treatment with aducanumab? So this was ARIA, which stands for amyloid-relating imaging abnormality. It's the most serious and concerning side effect of anti-amyloid monoclonal antibodies. It's important to remember, though, that most of the time ARIA is asymptomatic. It's something that we just pick up on routine MRI monitoring that's done as a part of treatment with this drug class. If patients do develop symptoms, though, they're typically a headache, confusion, visual changes, dizziness, nausea, and gait difficulty. However, there can be severe manifestations of ARIA that require inpatient care, and these include seizures, status, encephalopathy, stupor, and focal neurological deficits. And there have also been deaths directly related to ARIA. So from what I could gather from the media, there have been at least 3 deaths in patients who received aducanumab after its approval, out of a total of about 427 patients in the country who got it. So, a fairly high death rate for this medication. So how do we classify ARIA? So we look at 2 different things, radiographic classification, then also clinical classification. So radiographic classification is broken down into 3 different components. So first is the ARIA-E or edema, then ARIA-H, which is for the microhemorrhages, and then also look at superficial siderosis as well. And so this schema is used to grade the ARIA based on its radiographic severity. And so for our patient, given that he had this large area of flare hyperintensity, and he had 7 new microhemorrhages, the radiographic severity of his ARIA would be moderate. And then looking at the clinical classification, mild ARIA is characterized by some mild discomfort, but no disruption to daily activities. If it's moderate clinical ARIA, then it impairs daily activities. And then if it's severe, it's totally incapacitating. So in this patient, the visual changes were to the point where he wasn't able to drive. So it was moderate by clinical classification as well. And so how do we use this to make a treatment decision with respect to continuing or suspending the anti-amyloid monoclonal antibody? So if the ARIA severity on MRI by radiographic criteria is moderate or severe, then we suspend dosing. If it's just something that's picked up on routine imaging, that's totally asymptomatic and it's mild, you're able just to treat through that. If there are mild symptoms associated with it, then you can decide whether or not to continue treatment based on clinical decision-making and also, talking to the patient and their care partner. And then if there are moderate symptoms, then the recommendation is to suspend dosing. And then similarly for ARIA-H, if there's moderate ARIA-H, the recommendation is to suspend dosing or if it's symptomatic. And so for our patient, it was moderate by both clinical symptoms as well as on radiographic criteria. Similarly for the ARIA-H, and so the recommendation was made to suspend dosing, and the patient and his carer and his wife were in agreement with that. So his headache resolved over 2 days. Actually, she didn't reach out to me until a couple of days after this. And by that time, his headache was gone. He still had the dizziness and the visual changes, but those resolved slowly over the next 10 days. And then he was back to his baseline. At 6 weeks, we did a repeat MRI and found that there was still some evidence of ARIA, but it was resolving compared to the prior MRI. And then I saw him for follow-up earlier this year. Repeat MoCA was down to 17 out of 30 from 21 out of 30. And then repeat MRI showed resolution of the ARIA and then just stable to occipital microhemorrhages. And so the incidence of ARIA for the 3 monoclonal antibodies that are either FDA approved or nearing FDA approval varies pretty substantially based on the clinical trial data that we have available. And we also know that the biggest risk factor for ARIA is presence of the ApoE4 allele, which is also the strongest genetic risk factor for late onset Alzheimer's disease. And many of our patients are at least heterozygotes and carry 1 copy of this. You can see out of all the drugs, aducanumab has the highest incidence of ARIA, and lecanemab, which is the one most recently approved, has the lowest incidence. Donanemab, which will probably be approved later this year, is kind of in the middle. So lecanemab appears so far to be the safest monoclonal antibody for Alzheimer's disease. However, one of the drawbacks is it's every other week dosing. Compared to donanemab, which is once a month. So probably if you're an E3 homozygote, donanemab is a safe and logistically easier option. But if you're an E4 carrier, it's probably a safer bet to go with lecanemab. And so that's the drug that we'll be using in our clinic. And so this is the ARIA management specific for lecanemab. And so it's similar to what I showed before, but if you have ARIA-E or ARIA-H and it's asymptomatic, depending on the severity, you may want to suspend treatment if it's severe or moderate. If it's asymptomatic and mild, or symptomatic and mild, then the recommendation is to suspend treatment, and then in discussion with the patient. And after monitoring with monthly MRIs, once the ARIA is resolving, symptoms resolve, you can decide to continue treatment. However, if patients develop any macrohemorrhages or one area of superficial siderosis or more than 10 microhemorrhages, or have more than 2 episodes of ARIA or any severe symptoms related to ARIA, the recommendation is to stop treatment completely. And then Andy Liu, I think, presented inpatient management of ARIA, but it's basically supportive care with treatment with steroids. And then if patients are having seizure, kind of typical seizure management with benzos and anti-epileptic drugs. All right, thank you.
Thank you, Daniel. That was wonderful. Yeah, round of applause. So Daniel, if you send me your slides, I can distribute them to folks. That'd be great. I mean, who'd have thought that you're going to have to be a mathematician now to be a dementia doc, adding up 1s and 2s and 3s and 4s? All right, which one is Danelle? Which one is yours? Oh, BTK, yeah. All right, so Chris is going to introduce today's grand round speaker. Let me just get this teed up. Okay, Chris, take it away.
Morning, everybody, and welcome to Grand Round. So it's my pleasure this week to again get to introduce someone who pretty much everybody in the department already knows. So Danelvis is one of our current chiefs. So Dr. Paredes came from University of Puerto Rico, where she did her undergraduate degree, as well as an MPH, where she worked in biostatistics, and then followed by her MD. So she, over the course of her residency, has been very productive. She served as a QI chief for the last year, and along with Elijah Lackey, has recently published a manuscript looking at complications of sarcoid management. So next year, she's going to be headed off to San Francisco, where she landed a very competitive fellowship in neuroimmunology at UCSF, and I'm sure she's going to do very well there. As long as they pay their fellows well enough to live, I think she'll make it. So today she's going to be talking to us about BTK inhibition in MS, which is kind of the next new field in treatment mechanisms.
All right. Let me. Thanks so much for that kind introduction, Dr. Eckstein. I'm very excited to be here today. Thank you so much for those of you that are here in person and the ones that are via Zoom. So I'm very excited to talk about this new potential therapy that might be coming in 2024, the earliest, and it's called the Bruton tyrosine kinase BTK. So what I want to focus my presentation is essentially what preclinical data we have and what clinical data we have as an evidence of this treatment being a potential treatment for MS in the MS world. All right, so I have no disclosures. Now, I would like to start first with a very brief history behind the BTK inhibitor because its history is important. Then I'm going to talk about what the mechanism of BTK inhibitor is, followed by how this is linked to the multiple sclerosis world, presenting preclinical data, and then current clinical data. And then ultimately, I'm going to finish with some conclusions and take home message. All right, so let's start with the history behind BTK. So this very serious looking man, someone wants to guess what his name is? Bruton, right? Interestingly, so Bruton was a Dookie. So he graduated from Duke in 1926. And very surprisingly, he was a pediatrician. I know he looks very serious, but he was a pediatrician and he was an immunologist. He was very smart and he made a very good description of an 8-year-old kid that kept having essentially pneumonia, recurrent pneumonias. And he actually noticed that in the bloodstream, this patient had complete absence of gamma globulin. So for those, just a review from medical school, what we learned, what he was describing is X-linked gamma globulinemia, or XLA. And this is essentially either the inability to produce B cells or the inability to actually produce the immunoglobulins that are important for the production of the antibodies. So this was a very good, very important discovery, but sadly it took 40 years to actually be able to link the BTK that is an important mutation in this condition, XLA. In 1993 was when they actually noticed that BTK is expressed in B cells, hematopoietic cells, but more importantly, B cells. From there, they spent almost more than a decade trying to identify a good medication to inhibit the BTK so that they can actually produce a therapy for B cell cancer. It took more than a decade. 2007 is when the first class agent BTK inhibitor. Am I too loud?
I'm just going to turn the volume down a little.
Okay. Okay. All right. So, so 2007, the first BTK inhibitors are produced, right? And then from 2007 to 2023, there has been multiple BTK inhibitors that had been produced for B-cell malignancies. It's not until the most recent years where there has been an interest in utilize this mechanism to treat autoimmune conditions like MS, but also other conditions like lupus, Sjögren's, etc. So what's the mechanism of action of BTK? So as I already mentioned, is producing the B cells. And I, of course, don't want to overwhelm you with all this mechanism, but this is just to show you that BTK is an important enzyme on the B cells. And it is very important because essentially there is a downstream cascade, multiple downstream cascades that ultimately is important for B cell maturation, immune cell production, and cytokine secretions. Now, not only is produced on B cells, it's also noticed to be produced on myeloid cells and microglia. And again, the same as the B cells, this enzyme is very important in a downstream enzymatic reaction that has as a result activation of macrophages and microglia. So now we have shown that BTK is not only important in B cell pathway, but also important in the myeloid and microglia pathway. B cell, right, we know that it is very important in the MS world. We have a lot of high intensity therapies, but what is interesting in this pathway is the microglia and myeloid. And then I would like to take this time to explain why is this important in the MS world and how it's linked to the multiple sclerosis. So this graph, just as a review, and for those that are not associated with this graph, is very important for MS and try to understand the course of MS. So on the y-axis, we have the disability accumulation on the patient, right? In the x-axis, we have timeline. Now, just as for those of you that do not know, CIAs essentially stands for clinical isolated syndrome, which is when a patient has essentially a flare without any more flares. This can develop into a relapsing remitting phase and progress to a progressive phase where you have still disability, but less of the relapse. You can also go from here into a progressive phase from the beginning, which is not presented in this graph, but is still possible. And then we have, the relapsing remitting phase. So here we have two patients. One is the untreated patient and in gray, and the blue is the treated patient. So what happens? Of course, a treated patient that is on DMT therapies will have less relapses, right? And consequently, because he has less relapses, will have less accumulation of disability. Now, for every relapse, we have something called RAW, or relapse associated worsening, which means every time you have a relapse, your disability, there's a disability associated to it. Now, what is interesting and perplexing in the MS world that we still cannot completely understand, and Dr. Skin, if you guys are in Dr. Skin talk, which is very, very good, there is this part where is independently of any relapse of MS, there is a progression of disability. And that's the part that we are still trying to figure out, and it's called PIRA. There is several theories. And one of them is that these are two different processes going on. And one interesting theory that has BTK come into place is that essentially what we have is a compartmentalized inflammation in the CNS that is independent of the peripheral process. And these resident immune cells are the one that create essentially like a vicious circle, will create this accumulation of disability. Now, the current disease modifying therapies that we have right now has done an outstanding job on modulating the peripheral immune system. However, we have only a limited effect on the CNS compartmentalized inflammation. So this is when BTK inhibition, right, brings hope to a new era of MS treatment, where it's only not capable of treating the peripheral immune cells, but also is able to drive or to inhibit the CNS compartmentalized inflammation. And this is the thought of how BTK will be able to help the decrease in disability accumulation. Now, so just for a moment, so that we can understand how this works and how BTK inhibits in the periphery and in the central nervous system and how it decreases the disability. Let's imagine for a moment that we have a PhD in immunology, and let's dive deep into it. So right now, what happens with an untreated MS patient? So in an untreated MS patient, we have the peripheral cells right here. This is in purple. And then we have the central nervous system, which is marked here in brown. So what happens is that we have the self-antigens, right, which are present in the peripheral area. Now we have the myeloid cells that are activated by this antigen. We also have the B cells that are activated by this antigen. And both of them can activate T cells in the periphery. What happened after that? So after that, the T cells will go into the central nervous system, okay? And these activated T cells can't co-react with the microglial cells. Now, what happens when we have patients on high efficacy therapy like the CD20 anti-CD20s? Now we have an inhibition of the B cells. However, the myeloid cells, right, are still able to activate. And what it's going to do is that it's going to activate the T cells, and these are gonna create an inflammatory response into the CNS system, although it's gonna be more silent, it's still gonna be there. Now for BTK, what is thought is that essentially it also inhibits the myeloid cells, okay? So that the T cells are not gonna be activated either by the T cells or B cells. And also this molecule is very small. So it has the capability, some of them, not all of them, to get into the central nervous system and actually inhibit the microglial cells. So it's also involved in the myeloid and the microglia. Okay. Now this inflammation or active CNS inflammation is thought to be involved in the meningeal. So there has been some studies done, and here is just a diagram of biopsies. As you can see, there's a relapsing remitting MS in the left, and then a progressive MS phase. You can see in blue that there is significant demyelination. However, what is interesting is that there is meningeal pathology more significantly in the progressive MS form. So this is thought that when you have more meningeal inflammation, it is a predictive factor for progression of disability. And more importantly, it has also shows that the adjacent tissue next to the meninges is also affected. So what you will have is a degree of essentially neuronal dropout, cortical demyelination, as well as sclerosis. And this is what thought to drive essentially the cortical degeneration in the MS patients. Now, here we have essentially a meninges stain, and this is for a MS patient. We can see that there is a significant degree of T cells, but also B cells. They also, I'm not presenting it here, but there is also increased evidence of myeloid cells. And why is this important? Well, so basically BTK have shown in mouse studies or mice studies, as well as a bench work, right, that it has the capability of reduce meningeal inflammation and leptomeningeal contrast enhancement in mice. Okay, so here we have a mouse model, and what they did is that they randomized these mice into just receiving the vehicle, which was essentially just a alkalinic solution, and the BTK inhibitor. So what this is showing here is essentially hippocampal fissure enhancement around the meninges area. And what they did is that using high resolution MRI, they verified the change on contrast enhancement of the meninges. As you can see here, what they're trying to identify is that as weeks pass by, there is reduction on inflammation. Now, in the case of the vehicle, on the other hand, there is actually worsening of inflammation. Now, they also took the tissue for these mice and they evaluate the population on these meninges. And what they saw is that there is, again, just like how I showed you on the slides earlier, is that here on this inflammation, we're supposed to have, right, increased T cells, increased B cells. But when treated with this BTK inhibitor, there's actually decreased level of T cells as well as B cell population. The microglia population, they determined that was the same. Now, this is just to show you the same. Essentially, the red one represents the control, and the blue one represents the BTK inhibitor. So you can see as the weeks pass by, the meningeal contrast enhancement decrease. Now, I have shown that BTK can inhibit the meningeal inflammation, can also inhibit the CNS compartmentalized inflammation. And ultimately, what is also very interesting is that it has shown to restore myelin. So this was a study done in Germany. So what they did is that they took tissue from cerebellar region of the mice. And then what they did is that they utilized LPC, which is a demyelinating agent, and they added this to the cells. And what happened is that after several hours, there's debris. Okay, so this is the end of the demyelination. The green represents the myelin, and the red represents the neuron. And then they added the BTK inhibitor. And what you can see here, and if you aren't able to see it well, just believe me that there is more green, and which represents that essentially there is some component of remyelination. Not only they say that BTK inhibitor, they suggest that BTK inhibitors can repair myelin, but that also can inhibit the degradation and also inhibit the migration of microglia to the site of the demyelination. Okay, now I'm on the same line over here. On the left is the control. Again, green represents the myelin. In this case, BTK represents is the red. They added LPC, which is again the demyelinating agent, for 16 hours. And what you can see here is that the BTK is overexpressed in demyelination. Okay. Now, let's take a stop here and just overview what we have discussed so far. So this preclinical data essentially suggests right, that BTK can reduce this disability accumulation that I talked earlier by inhibiting the compartmentalized CNS inflammation, but also by reducing the meningeal inflammation, which consequently reduce the cortical damage that we can see in MS. And ultimately can even repair and restore the myelin. But again, all this data that I have shown, right, is from rats, is from bench work. We are not rats, we are not petri dishes, right? Does this actually really work in the real world? And right now, can you guys hands up the ones that you think that actually this could work in the real world, right? Like we can extrapolate what we are seeing in the bench work to the MS population. So hands up the ones that think that this could really work. There could be good, okay. Hopeful people, I like it, or maybe I just convinced you. Who think that it's not, that it doesn't? Okay, so Dr. O'Brien. Dr. Skeen. Oh.
That's a caveat.
Okay.
So we have trouble measuring in humans.
Yeah.
So does it work or does it not? It may be challenging.
Exactly. So currently there are 7 clinical trials trying to prove this. And they're in different phases, right? One of them are in phases 2, phase 3 trial. I'm going to present only just for the interest of time, the results on tolebrutinib. And the reason is because it's the one that is most advanced and also is the one that actually has shown to have more CNS penetration in comparison with the other BTK inhibitors. They're currently on phase 3 trial, where I'm going to present phase 2A and 2B. So essentially the variables of interest or endpoints for this were the annual relapse rate. They also evaluated for changes in MRI, the disability score, and side effects. And this is essentially basics of what every MS clinical trial tried to evaluate. So essentially what they did, and they collected data from for like 2.5 years. So they had 2 cohorts. There's cohort 1 and cohort 2. The cohort 1 for 3 months or 12 weeks received the drug at different levels, right? Different dosages. And then they collected the endpoint that I just discussed and run a placebo or nothing for 4 weeks and collected again that data that that's variables that I mentioned. In cohort 2, what they did is that essentially they initially run for 4 weeks placebo and had collected the endpoint. And then also essentially what they did was the opposite of the cohorts, right? They have a minor gap here, and this section right here is just to evaluate the long-term side effects of the drug. Eventually, they determined that 60 milligrams per day was safe, so they continue 60 milligrams per day for the rest of the 2.5 years. This part here is the double-blind period, but after here, the patients are not blind anymore. Now, so in terms of the annual relapse rate, here for some reason, they just show the one that is for 60 milligrams. And what I think is because is the one that actually showed to have some significant effect. So this is just the analysis on the arm that were on 60 milligrams from the beginning and continue with 60 milligrams throughout. So before the trial, this is the relapse rate, which is 1.5 average. And then this is 2 years after, which is close to 0. They also showed that, and again, this is for the 60 milligrams arm. So the patients are starting at 60 milligrams and continue. They show 93% did not have any relapse. And then 7.1% had 3 relapses. Now, in terms of MRI changes, they evaluated for new gadolinium enhancing lesions. And I know this looks very crowded, but I think that what is just important here is on the double-blind period, what you can see an actual effect is on the higher dosages, which is for 60 milligrams and also for the 30 milligrams. For the 5 and 15, you actually, if anything, you see an uptrending. So it doesn't seem like it really helped much with 5 or 15. Now, this is at this period is when everyone switched to 60 milligrams, and you can see that it kind of stabilized. Now, they also evaluated for new T2 lesions per month. And again, you can see the same pattern here where the 30 and the 60s are the ones that seem to do better. And then the 5 and the 15 did not help that much. And then in terms of the disability scores, this is just briefly to show that the disability stayed the same in almost every group. There was no significant difference. Now, in terms of actual treatment emergence adverse events, it was not bad. Most significantly, they noticed COVID infections. They say that only 2 of these 31 patients actually needed to be hospitalized. The rest of them did okay. And then the other side effects that you see are honestly the ones that you see on all disease modifying therapies, which is some infections like cystitis, nasopharyngitis, and upper respiratory tract infection. There were 4 patients that needed to discontinue the treatment, and the reasons were because transaminitis, trichorexics, which is essentially thinning of the hair, and headache. Now, they noticed that there was no new signal or side effects on the current dose, which is the highest dose, 60 milligrams. So the conclusions of the clinical trial that is going right now, it shows again that the relapse rate was low, that they remain, a significant number remain with no relapse for the 2.5 years period, that the MRI lesions were stable, at least the T2, and in the population that used 30 and 60 milligrams, it actually the enhancing lesions decreased, and that it had a safety profile. Now, where are we right now? Currently, they think that their estimated time of completion and product availability is for October 2024. However, there's actually a partial hold on this because in the 60 milligram arm, they are starting to notice significant transaminitis. The ones, you know what, when I discussed with the pharmaceutical, what they said is that the transaminitis is not fatal or too much, and that it normalizes afterwards. They see that is like within the 70 days of starting the high dose is when they see the change. So for those that are in the treatment for more than 70 days, is what they think, for more than 70 days and don't develop transaminitis, then they think that it's safe. I'm not so sure. I'm not sure. I didn't ask that, but. So there's also a thought, which I think is very interesting, and we really need it. And it's the trial for primary progressive MS, because the results that I show you was for relapse and remitting MS and secondary progressive MS. But really what we need is for this is what we are trying to identify with BTK is that it can decrease this disease progression that is not associated to the relapses. So I'm going to end with some take-home message. Now, very important, right, that we still don't know very well the cause of PIRA. There's some theories, but we need to continue to investigate so that we can provide better therapeutic MS options. Now, BTK inhibitor seems a promising option to combat MS. One, because of this inhibition of the CNS inflammation, the probability of reduced meningeal inflammation, and also the capability of repair myelin and protect the myelin as well. And let's say that this doesn't work, because it could happen, right? Science is like that, it's unpredictable. This is still exciting and honestly encouraging that we are finally, after several years of just treating with the same drugs or with same mechanism of action, we are actually start to move to the pathway of trying to identify different mechanism of action of the progression of the disease. So this is a very exciting news for MS, regardless of what the end will be for this drug. At least that's my take-home message. Thank you so much for your time. I know this is a very, very, very hard topic in the sense that there's a lot of mechanism of actions and things like that, but thanks for your time. And I hope you guys learned something today. I really want to thank the Duke faculty for being such great mentors and help me develop my career. I'm very grateful for you all. And thank you so much to my class and my other co-residents. You have become a second family. And this is the best resident right here. And last but not least, thank you to my family who means the world to me, and to Luis, my significant other. Thank you so much. And now we have plenty of time for some comments and some questions, concerns.
All right, questions in the room?
And can you repeat the question so the remote viewers can hear?
So okay. So the question from Tensia is that the population that they selected on this, or the cohort on this trial, if they were on any therapy beforehand, or they had, one of the inclusion criteria was not to be on any therapy. My understanding is that they did not discriminate, but I will have to check. Yeah, thanks.
So if anyone on the internet has any questions, please pop up. So Mark?
Sure.
I'm very curious to know about your comments.
Yeah, so I guess I'll ask it as a question, right? So the phase 3 trials that will be reported in the next year or two, it may lead to approval. Mostly have to do with relapsing disease.
Mm-hmm.
And there will be endpoints measured as secondary or tertiary endpoints that may reflect the disease progression independent of relapse and stuff we were talking about. So is your take on the data you've seen that this is a more highly efficacious drug for relapsing disease than what we already have? It's a long question.
Yes.
And so, yeah, I'll leave it there.
Mm-hmm. So Dr. Skeen is asking, I'm going. So Dr. Skeen is asking if, so essentially the current trials, right, that are going on for relapse and remitting MS or secondary progressive, and the endpoints that they're gonna evaluate is for this population. The question is, do we think that this new therapy is equally efficacious as the current therapies that we have that are high intensity therapies, or do we think that this is going to be above that? And I think my short answer for that will be that we won't know until later, and we see in the clinics, and we can start seeing actual, right, like patients and see how they react. So far, it looks like in terms of relapse, it has a very good control. So 93% of the patients had no relapses for almost 3 years. So yeah.
Yeah, and so my comment is, so I think as these drugs kind of in the dark, as we always are,
Mhm.
to know how we prefer to use them. And most of our particular desire for BTKs will continue to be on surrogate markers and stuff we really don't know. I mean, you know, the opportunity to impact progressive disease, if it's real, we should be starting with these drugs in the very beginning, in my opinion. We shouldn't be waiting till we see progression. But I think all that will remain pretty theoretical and hard for us to judge the reality of that for quite a number of years, probably. So it's going to be, like it always is, we're going to have opinions and ideas, but we're not really going to know what we're doing.
Exactly. Yeah. Dr. Skin is mentioning that essentially we won't really know, what, like how to proceed probably for several years. Because right now the approach that we have is like start high efficacy therapy in patients as soon as possible instead of waiting for relapses, because that's what scientific evidence have showed that is the best approach. But right now with this medication, since it's so new, we won't be able to identify, oh, is this actually like very high efficacious equally as the other ones that we already have in our pocket, and we might just preemptively just go to the ones that we actually have and know for several years. I do think.
Katie Peters has a question. Her hand is up.
Hey, Danelvis. Sorry, I'm great presentation, wonderful. Interestingly enough, we use these in primary CNS lymphoma, and you probably already know that. We actively have ibrutinib in the clinic, and tirabrutinib is in a clinical trial that is starting here at Duke very soon, in a trial called Prospect for primary CNS lymphoma. And there's another company called Gossamer that has a lead compound called GB5121, which is thought to even penetrate the blood-brain barrier even better and into the also into the vitrea to treat both primary CNS lymphoma and vitreal lymphoma. I think what's fascinating is we're learning a lot about these agents. I find the connection between CNS lymphoma and demyelinating disease sort of intriguing in regards that we're using always the same, we're using sometimes the same drugs, but could you posit to sort of the etiology and the sort of the etiology of this, but then also do you know anything about the utility of those other agents in MS?
So right now for MS, the ones that are being checked, it's like the tolebrutinib, which is the one that I mentioned, and then ibrutinib is the other one. There's a third one that I'm trying to remember the name, but they haven't even started yet the trial. So essentially, we just have these two only, and out of these two, tolebrutinib is the one that seems to have the best CNS penetration, but we don't have that many options right now because essentially we are just kind of starting to utilize these therapies for other diseases other than lymphoma. But it could potentially be that if you mentioned that there is actually another one that has more even more CNS penetration.
It's a company called Gossamer, and they have a compound called GB5121. Has really great, and we're using tirabrutinib is already FDA approved in Japan, and it has very good penetration into the CNS. Also, that company is Ono Pharmaceuticals, who, interestingly enough, developed the first checkpoint inhibition. So they've been in the immunology/oncology space for years. They're the oldest pharmaceutical company in Japan. So I would actually look into those and see what their pipeline is and what they're interested in, because you could even find a better, potentially a drug that has better CNS penetration. It would be very intriguing to see.
Certainly.
The overlap between MS and lymphoma drugs and diseases. Lymphoma is like
That lymphoma is like MS?
What about, why did the same drugs work?
Yeah, exactly. Because we do know that right, these immune cells like B cells and T cells are involved on these processes, on both of them. The pathway is a little little bit different, but certainly we recognize that is essentially the hematopoietic cells that are affected, and that's why now we are actually trying to utilize these same therapies not only for MS but for all other autoimmune diseases.
One last
Yeah.
question. Nothing left? Oh, I have a question then, Darren. So chronic progressive MS, do you think that's a different disease or the same disease in an older person?
So I do. The short answer is I don't know. But I will guess, and I would think that based on what Dr. Skeen show us, is that likely there are two different processes, right, going on. Like just like the graph that I show, which is like there's a process associated to relapse, but there's a process that is not associated to the relapse. So definitely there's research that needs to be done.
Might also be repair too, which might be missing in an older person.
Yeah, but then how do you explain that you have people that even from the early stages, it has a progressive form?
But are they young?
They're not, yeah,
They're young?
yeah.
Well, I mean, that's something to study.
Yeah, exactly. And I think it's fascinating and it's interesting. And we need people to work on this. And we'll see. I have big hopes that in the next several years, we will have more therapies for this progressive.
So do you think the mechanism that underlies kind of primary chronic progressive MS
Mm-hmm.
is the same as the mechanism that leads to chronic disability in people with relapsing?
I'm not sure. I wonder if Dr. Eckstein or Dr. Sumasha or Dr. Skeen can comment on this, what your thoughts are. Yeah.
I have a feeling, it's a feeling, not
Mm-hmm.
really fully evidence-based, that some of the neurodegenerative components of chronic progressive MS that are active at the onset are what are sort of taking over as a primary mechanism of action
Mm-hmm.
in relapse and remitting MS when it becomes more secondary progressive stability. But it's in the face of the relapses that have already happened.
And I would just say it depends on if you ask a clinician or a pathologist or a radiologist. So the answer is we don't know. To
Mm-hmm.
clinicians, it looks pretty similar.
Mm-hmm.
To pathologists, not so much. But that may just be the difference between how well developed that process is. For all the meningeal inflammation and the B cells that are in the meninges and stuff, we see that mostly in secondary progressive, a little less in primary progressive, which we just don't understand that at all if they're the same process.
Mm-hmm.
But clinically and radiographically, it looks like the same disease. So it's a question we're all trying to answer. We don't know.
Yeah. So essentially, just to kind of review what we just said, that we are still trying to figure out the answer. Clinically, they both look the same, but if you ask like pathology, for example, they might differ. So yeah. All right. Well, thank you so much, everyone. You have a good day. Bye. People are not paying attention.